Assalamu alaikum. I am Dr. Mahmud Tusar, lecturer, Department of Pharmacology in Bashundhara Ad-din Medical College. Today, our topic of discussion is anti-tubercular drugs. First of all, I would like to say some important things about mycobacterial tuberculosis. Mycobacteria are intrinsically resistant to most of the antibiotics because they grow slowly compared to other bacteria. Mycobacterial cells can be dormant. The lipid-rich mycobacterial cell wall is impermeable to many agents. Mycobacterial cells are intracellular pathogens residing in macrophage. Now, anti-TB drugs. First-line anti-TB drugs are isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. Second-line anti-TB drugs are amikacin, capreomycin, kanamycin, para-aminosalicylic acid, ethionamide, rifabutin, clofazimine, fluoroquinolones. Isoniazid. It is a highly efficacious synthetic and prodrug. It is selective against Mycobacterium tuberculosis. It acts against rapidly multiplying organisms. This is an important topic, very important, and it is also tuberculosidal. Pharmacokinetic properties are: it is given orally, it is well absorbed from the GIT, can cross the blood-brain barrier and meninges. It is metabolized by the slow and rapid acetylation. It is excreted by renal route. Now, mechanism of action of isoniazid. Integral component of the Mycobacterium tuberculosis cell wall is mycolic acid. Mycolic acid synthetase helps in synthesis of mycolic acid. Isoniazid block mycolic acid synthetase enzymes. So there is no synthesis of mycolic acid and no cell wall synthesis causes ultimately death of the MTB, Mycobacterium tuberculosis. Now, what are the adverse effects of isoniazid? Here, the most important adverse effect is hepatitis. It more occurs in rapid acetylators, and peripheral neuropathy mainly occurs more in slow acetylators. Most of the people in our countries and the South Asian regions are slow acetylators. And hypersensitive reactions such as rash, urticaria, SLE, etc. CNS disturbances are convulsion, seizure, memory loss, and insomnia. And GIT upset, hematological, some abnormalities. Now, rifampicin. Rifampicin, it is a broad spectrum antibiotic and tuberculosidal. These are enzyme inducers. It acts on both extracellular and intracellular organisms. It acts slowly, multiplying bacteria. The first one was isoniazid was acting on rapidly multiplying organisms, but now in rifampicin it only acts mainly slowly multiplying bacteria. It is also active against many gram-positive and gram-negative bacteria and Legionella and Meningococcus. It is metabolized by liver and excreted by bile and urine. Mechanism of action of rifampicin. It inhibits mainly DNA-dependent RNA polymerase, and it interferes RNA synthesis, so there is no protein synthesis and ultimately bactericidal in action. Now, what are the adverse effects of rifampicin? The most common adverse effects are liver damage, cholestatic jaundice, and influenza-like syndrome or flu-like syndrome, allergic response, GIT upset, microsomal enzyme inducers. It acts as mainly microsomal inducers, and it causes therapeutic failure of many drugs due to rapidly metabolizing of these other drugs. A special note about this drug is it changes the body fluid, the color of the body fluid, such as urine, tear, saliva, sweat, etc. etc. are color change to orange color due to its metabolites. Now, pyrazinamide. It is a prodrug and synthetic drug. It is much more active against dormant bacilli. By adding this drug, it has shortened the duration of treatment. It prevents relapse. It is widely distributed to bone, meninges, and other avascular structures. Now, mechanism of action of pyrazinamide. It is taken up by macrophage. It is converted to pyrazinoic acid by intracellular enzyme pyrazinamidase. It causes acidic environment and it has sterilizing effects. It kills the organisms. Now, what are the adverse effects of pyrazinamide? It causes hyperuricemia, and hyperuricemia leading to causes gouty arthritis. It is also hepatotoxic and GI upset. We will give advice to patients baseline and periodic serum uric acid level check korte hobe. Now, ethambutol it is a synthetic drug and it is a prodrug. It is tuberostatic. All the anti-TB drugs are bactericidal except ethambutol. It is tuberostatic. It is selective for Mycobacterium tuberculosis. It is less lipid soluble. Now, mechanism of action of it inhibits mycobacterial arabinosyl transferase. It prevents arabinoglycan formation and cell wall is defective anti-TB action. What are the adverse effects? Adverse effects are color blindness, retrobulbar neuritis, loss of visual acuity. We will give advice to patient periodic baseline and periodic visual acuity test. And what are the contraindications? Are the children below 6 years of age. Streptomycin. Streptomycins are its sources are actinomycetes. It is polar and mainly water-soluble drugs. It is polycatonic drug. It is active against extracellular organisms. It binds with the 30th ribosomal subunit of the bacteria and it inhibits protein synthesis. There are some adverse effects of streptomycins. It causes ototoxicity, nephrotoxicity, and it causes neurotoxicity. Now, rationale of combined use of anti-TB drugs. To obtain better therapeutic efficacy, to broaden the spectrum of coverage, to reduce the toxicity, to avoid resistance, to prevent relapse. That's why we use all the combined use of anti-tubercular drugs. Now, TB treatment regimen updated. This is this figure showing the updated national guideline for tuberculosis. Now, this chart showing the how much FDC is required according to the weight. Now, what are the conditions for using second-line drugs? Resistance to first-line anti-tubercular drugs, failure of clinical response. Conditions for using second-line drugs. Resistance to first-line drugs, failure of clinical response to conventional therapy. In case of serious treatment, limiting adverse drug reactions. When expert guidance is available to deal with the toxic effects. Thank you all. This is for our topic.